I'm Miranda Harrison, and I'm going to be speaking today about peptic ulcer or peptic acid disease. Our case study is as follows. Tom is a 48-year-old man. He's been waking up with heartburn every night. He has been taking omeprazole 40 milligrams daily over the counter, and it's only helping a little. He read on the internet that there are some antibiotics that could help his problem. He has a $5,000 deductible, so he doesn't want to see a specialist. Before we start to treat Tom, we have to determine how he was diagnosed with peptic ulcer disease. He could have just read about it on the internet and started taking Prilosec on his own, and something more serious could be going on. Getting some more information from Tom can help us save him some money and rule out some of the more serious diagnoses. If he had appendicitis, we could presume that he would have fever, chills, anorexia, bloating. He would be more likely to have a bowel obstruction if he had prior abdominal surgery. If he had a AAA, he would have a low blood pressure and decreased peripheral pulses. He'd be more likely to have pancreatitis if he drank a lot of alcohol or if the pain got worse at night or when he laid down. If Tom had gallstones, we could presume that he would be vomiting and the pain would be worse after eating, especially fatty foods. And if he had GERD, the pain would be more in his neck and throat. Rarely, someone like Tom could have Zollinger-Ellison syndrome. That's a gastrin-secreting tumor, but it only accounts for 0.1% of duodenal ulcers. If his symptoms persist and are resistant to treatment, we can check a fasting gastrin level or some other blood test to rule that out. Let's say Tom's symptoms are consistent with peptic ulcer disease. We could expect him to present with epigastric pain, gnawing or burning sensation after meals, generalized abdominal pain, sudden onset worsened by any movement, epigastric tenderness or right upper quadrant tenderness, positive hemocult, rebound tenderness, guarding rigidity, even shock symptoms such as tachycardia or hypotension. Common risk factors for peptic ulcer disease include stress, H. pylori, alcohol, and smoking. Peptic ulcer disease is a break in the mucosal lining of the stomach or duodenum with depth to the mucosa. The two main types are the duodenal and the gastric. The idea that ulcers can be caused by stress is debatable, but this could be caused by an increase in ACTH, which increases the levels of cortisol. In addition to our treatment, we can ask Tom to make some therapeutic lifestyle changes to decrease his symptoms, such as stopping smoking, stopping drinking alcohol, eating 5 to 6 small meals rather than larger, less frequent meals, stopping NSAIDs if possible, or if he has no cardiovascular risk factors, he could switch to a COX-2 inhibitor. We can also recommend many different kinds of medications for Tom. Antacids neutralize hydrochloric acid. They work very promptly, but they have a lot of drug-drug interactions related to absorption, and they can cause hypokalemia. H2 receptor blockers block hydrochloric acid formation. They have a lot of drug-drug interactions because they inhibit cytochrome P450 metabolism, which can cause an increase in the bloodstream of other drugs metabolized in this fashion. Proton pump inhibitors are the recommended first-line treatment in the U.S. There's no evidence to support one particular proton pump inhibitor over another. They do take longer to work. They prevent symptoms. They decrease the gastric acidity. And this can cause an increased risk for pneumonia due to the increased bacterial colonization of the stomach and secondarily the respiratory tract. Right now, our patient's on the maximum dose of omeprazole unless he has a hypersecretory condition such as Zollinger-Ellison. Prostaglandins, such as misoprostol, specifically protect the stomach against the negative effect of NSAIDs, but they can cause a miscarriage. So if Tom has a pregnant wife, he might not want to have that in his house, although research shows safe handling of the drug reduces the risk. Mucosal protective agents, such as sucralfate, coat the stomach for protection and can stimulate angiogenesis to promote healing. Bismuth has a direct antimicrobial effect against H. pylori, and we will talk more about antimicrobial in a minute. What are the chances that Tom has H. pylori? That depends on his family history and his ethnicity. Since Tom's a male, he's slightly more likely. If Tom had a low socioeconomic status, he would be more likely. He can inherit it from his mom or dad. If he had a large number of siblings, he was from a developing country, and he had an ethnicity other than non-Hispanic Caucasian, he'd be more likely. The American College of Gastroenterology says that everyone who tests positive should be treated. and testing should be performed on every patient with a new diagnosis of peptic ulcer disease or a history of peptic ulcer disease that's not been previously treated. So Tom qualifies for testing. Because Tom is less than 60 and he has no alarm features, we can use non-invasive testing measures so he doesn't have to have an upper GI or a biopsy. Primary resistance is increasing, so we do have to test him before we treat him. One annoying thing is that all tests that use urea as a marker, such as the breath test and the stool sample test, require the patient to stop his proton pump inhibitor, bismuth, or antibiotics 7 to 14 days prior to the testing, so you may have to deal with some symptoms during that time. Now, since he has such a high deductible, we want to use the cheapest, most effective test. The fecal antigen test is the most effective. It's mid-range as far as price goes. It is recommended by the American College of Gastroenterology. The serum antibody test is the cheapest, but it is the least effective because it doesn't specifically test for active infections. The breath test is the most expensive, and it can be done incorrectly if the patient doesn't take a deep breath and pause before breathing out to maximize the CO2 in the lungs, or if they don't adhere to the NPO timeline before testing. If Tom does test positive, the American College of Gastroenterology recommends several different lines of therapy. The first line of therapy is a proton pump inhibitor, clarithromycin, amoxicillin, and has dosing 4 times a day. If the patient's allergic to penicillin, or if the antibiogram indicates regional resistance to macrolides in our area, we would go to the second line of therapy, which is a proton pump inhibitor, bismuth, metronidazole, tetracycline, and that also doses 4 times a day. The third line or rescue therapy is used if the patient fails one of the previous lines of therapy and still has symptoms. All of the therapies are about 10 to 14. Only the second line of therapy recommends bismuth, and this is a really interesting drug because it lessens symptoms and helps the patient to heal. Sucralfate does this too because it stimulates angiogenesis, but it doesn't work specifically against H. pylori like bismuth does. Bismuth displays bactericidal action against H. pylori by disrupting its cell wall. This is because bismuth is a heavy metal, and small amounts of heavy metals can be toxic to a number of microbes. Bismuth also inhibits urease activity, which is necessary for H. pylori to bind to and colonize the mucosa. Bismuth is metabolized to salicylic acid, and when it does that, it inhibits prostaglandins and leukotrienes that are responsible for inflammation and hypermotility. And it's sold under the brand name Pepto-Bismol for less than $10 for an 8-ounce bottle. Bismuth is eliminated through the hepatic and renal systems, so we don't want to recommend that Tom takes this if he has renal or hepatic impairment. Also, it cannot be given to children, and it cannot be given to pregnant or nursing moms because it is excreted in the breast milk, and it also crosses the placenta, which can cause Ray's syndrome because it metabolizes the salicylic acid. The British National Formulary doesn't recommend bismuth because it can cause neurotoxicity and encephalopathy, but this is more common if the drug is taken in high doses or if it's used for more than 6 weeks. Due to the low doses and the short duration of therapy, bismuth for the treatment of H. pylori is safe and well tolerated. Bismuth can decrease the serum concentration of tetracycline antibiotics such as doxycycline, and the recommended doses in the second line of therapy do reflect that. A few things that we should discuss with Tom before starting him on bismuth include recommending that he does not take any additional aspirin, and that we monitor his blood pressure closely if he's on any antihypertensives. Bismuth can cause your tongue to appear black and or cause your stool to appear black or gray due to the medication combining with trace sulfur in the drug. The discoloration is temporary and harmless. Bismuth can cause constipation. It can also increase your chances of bleeding or make your ulcer worse. It can also mask bleeding because it causes discoloration of the stool. It can cause a metallic taste in your mouth. That's also temporary and harmless. Salicylates can cause an enhanced hypoglycemic effect. So if Tom was diabetic, we would want to keep a close eye on his blood sugars. So in conclusion, Some major risk factors for peptic ulcer disease are H. pylori, alcohol, smoking, and NSAIDs and stress. Several different medications are available to treat Tom's symptoms and make him more comfortable, including antacids and mucosal protective agents, but proton pump inhibitors are the recommended primary therapy in the United States. Because Tom is still having symptoms while taking a proton pump inhibitor, in order to treat him, we have to eliminate H. pylori from the equation and work on Tom's modifiable risk factors. If Tom tests positive for H. pylori, he should be treated with antibiotics, proton pump inhibitors, and potentially bismuth salicylate.